everyone, my name is Huiqin. I'm a resident in the gastroenterology department at the Huiqin Hospital.
My name is John Kim. I'm an assistant professor with the Division of Gastroenterology at Loma Linda University Medical Center, and also a visiting professor at Huiqin Hospital. On behalf of our co-authors, I would like to thank GIE for the opportunity to discuss our findings from a recent publication titled Accuracy of ASGE High-Risk Criteria in the Evaluation of Patients with Suspected Common Bile Duct Stones. For hospitalized patients with suspected common bile duct stones, the mainstay practice for decades has been to use baseline liver tests and abdominal ultrasound to decide on the need for ERCP. When the initial tests are inconclusive, then often serial liver tests were then performed to evaluate and further assess the need for ERCP. However, the development of highly accurate and non-invasive testing modalities to evaluate for common bile duct stones, as well as increasing recognition of adverse events associated with ERCP, sometimes severe, it has become more important to accurately select patients who would benefit most from a therapeutic ERCP. The current ASGE guideline defines high risk for common bile duct stones based on baseline liver tests and abdominal ultrasound when it meets one of the four following criteria. First, common bile duct stones seen on abdominal ultrasound. Second, bilirubin levels greater than 4 mg per deciliter on presentation. Third, bilirubin levels greater or equal to 1.8 mg per deciliter on presentation with a dilated common bile duct. Fourth, clinical cholangitis. So if a patient meets one of these four ASGE high-risk criteria, the guideline recommends these patients to proceed directly to ERCP, while others should receive lesser invasive testing such as MRCP or EUS. However, the current ASGE guidelines are based on older studies that typically included only patients who underwent ERCP, while excluded those who only underwent MRCP or EUS, leading to a possibility of bias. Furthermore, the sample sizes were small, and a majority of the studies predated the routine use of MRCP and EUS in clinical practice. Personally, after performing frequent negative ERCPs while using the ASGE high-risk criteria, prompted impetus to perform the study. The aim of our study was to determine whether ASGE high-risk criteria can accurately select patients with suspected common bile duct stones where the risk of ERCP is justified.
We evaluated more than 2,700 patients hospitalized with suspected common bile duct stones at the Huiqin Hospital located in Hangzhou, China, over a 3-year period. Patients who received at least one form of definitive testing for common bile duct stones, defined by MRCP, EUS, ERCP, intraoperative cardiogram, or common bile duct exploration following abdominal ultrasound and liver test were evaluated. In our study, approximately 40% of patients met the high-risk criteria. A specific ASGE high-risk criteria was 74%, and the positive predictive value was 64% for common bile duct stones. When we utilized only two factors, common bile duct stones on the ultrasound or bilirubin more than 4 mg per deciliter with a dilated common bile duct, a specific improved to 94% and positive predictive value to 85%, and a quarter of the study population met this criteria. When we looked at a subset of more than 1,200 patients who had serial liver tests, doubling or more of bilirubin to more than 4 mg per deciliter or more than 1.8 mg per deciliter had a high specificity of 98% and 95%. However, positive predictive value were low at 62% and 54%, and these factors and only at most 6% additional patients were not identified by common bile duct stones on the ultrasound or bilirubin more than 4 mg per deciliter with a dilated common bile duct on presentation. Our study demonstrated that the current ASGE high-risk criteria applied to our patient population will lead more than 1/3 of patients to receive diagnostic ERCPs. A more stringent criteria with common bile duct stones on abdominal ultrasound and bilirubin more than 4 mg per deciliter with a dilated common bile duct improve the specificity to 94% and the positive predictive value to 85%. Finally, serial liver tests identified only a small portion of patients who were not initially identified by common bile duct stones on ultrasound or bilirubin more than 4 mg per deciliter with a dilated common bile duct.
Although our results in the Asian population requires validation, other recent U.S. studies also demonstrate inadequate specificity and positive predictive value of the ASGE high-risk criteria, leading a substantial proportion of patients to receive diagnostic ERCP. Given the adverse events associated with ERCP, as well as readily available non-invasive alternative testing modalities, we would like to propose a revised algorithm with a more stringent criteria that only includes common bile duct stones seen on abdominal ultrasound and/or bilirubin levels greater than 4 mg per deciliter with a dilated common bile duct to improve patient selection and to reduce the risk of diagnostic ERCP. Otherwise, the majority of patients who do not meet these two criteria should undergo MRCP prior to considering ERCP. Thank you very much, and we look forward to your comments.